Welcome all of you for this lecture presentation on chemotherapy of tuberculosis part 2. The specific learning objectives of today's lecture is the student should be able to describe the chemotherapeutic regimens for the various categories of tuberculosis, describe the prophylactic regimens used for tuberculosis, describe the management of adverse drug reactions of various antitubercular agents. Describe the role of corticosteroids during the treatment of tuberculosis. Describe the management of HIV-infected tuberculosis patients. Describe the treatment and prophylaxis of Mycobacterium avium complex infections. Let us first discuss the chemotherapy of multi-drug resistant tuberculosis, MDR tuberculosis. By definition, this is the resistance which is seen towards Isoniazid and Rifampin with or without resistance to any other number of first-line antitubercular drugs. That is the definition of multi-drug resistant tuberculosis. And this resistance is diagnosed with the help of liquid culture drug sensitivity testing, which takes a long time. And recently, there are some genotypic testing methods like line probe assays and also CBNAT, which is called as cartridge-based nucleic acid amplification test, which are rapid diagnostic tests to find out the resistant status of tubercle bacilli. So this has in fact revolutionized the treatment of drug-resistant tuberculosis. 3% of newly infected cases of tuberculosis patients and 12 to 17% of retreatment tuberculosis patients are found to have MDR tuberculosis. India has the highest burden globally. 71,000 MDR tuberculosis patients are diagnosed annually in our country. The treatment is complex because it includes second-line antitubercular drugs. It's of a long duration. It's almost 24 to 27 months. The infection has a faster course. The mortality is also more in this type of tuberculosis. Our country adopted the DOTS Plus program under the revised National Tuberculosis Control Program in 2000 to include the diagnosis and treatment of multi-drug resistant tuberculosis. Now, the principles of the treatment of MDR tuberculosis includes using 4 effective antitubercular drugs. To ensure the efficacy, 6 of the drugs are employed. And these drugs are selected from group 1 to group 4 in a hierarchical order. The intensive phase, which is aimed at rapidly killing the bacilli, rendering the patient symptomatic and to achieve sputum negativity so that the patient becomes non-contagious, is 6 drugs are used for a period of 6 to 9 months. The continuation phase includes 4 drugs for 18 months. Duration is for 24 to 27 months, and pyridoxine is mandatory whenever we are treating MDR tuberculosis patients. How we include the drugs from group 1 to group 4. We include ethambutol and pyrazinamide from group 1 because rifampin and isoniazid cannot be used. That is the definition for MDR tuberculosis. From the injectable second-line antitubercular drugs, we choose amikacin, levofloxacin from group 3 fluoroquinolones, and from the group 4 second-line oral antitubercular drugs, etonamide and cyclosatin. So the intensive phase includes 6 drugs for 6 to 9 months, And in the continuation phase, we remove pyrazinamide and the injectable amikacin and continue with the remaining 4 drugs for 18 months. So the total duration of treatment is for 24 to 27 months. Now, the regimen for rifampin resistant tuberculosis, by definition, the tubercle bacilli are resistant to rifampicin. And we have to consider these patients as multi-drug resistant tuberculosis patients. The only difference is the tubercle bacilli are still sensitive to isoniazid. So what we do is we choose the same regimen as we choose for MDR tuberculosis. What we do is we just add isoniazid to the intensive phase and the continuation phase. So the treatment is the same as that for MDR tuberculosis. The only difference being we add isoniazid to the existing regimen. So the intensive phase is 7 drugs for 6 to 9 months. Continuation phase is 5 drugs for 18 months. Monodrug resistant tuberculosis means resistance towards any one of the first line anti-tubercular drugs, but not to rifampicin. So here we choose rifampicin plus 2 more drugs from the first line anti-tuberculars towards which the bacilli are sensitive. We add one injectable second line anti-tubercular, that is one from kanamycin, amikacin, capreomycin, and we add one fluoroquinolone. So we have 5 drugs in the intensive phase for 3 to 6 months. The continuation phase, we remove the injectable and continue the 4 remaining drugs for 6 months. So the duration of treatment for monodrug resistant tuberculosis is 9 to 12 months. Polydrug resistant tuberculosis means resistance to more than one first line anti-tubercular agent without resistance towards rifampin. So we use rifampin plus one first line anti-tubercular drug, add an injectable, add a fluoroquinolone. Now we add one drug from group 4, either ethionamide, cycloserine or para-aminosalicylic acid. The intensive phase includes 5 drugs for 3 to 6 months. The continuation phase, we remove the injectable and continue with the remaining 4 drugs for 6 months. The duration of treatment is 9 to 12 months. Now the regimen for XDR tuberculosis, extensive drug resistant tuberculosis. First of all, XDR tuberculosis is nothing but MDR tuberculosis where the tubercle bacilli are not only resistant towards isoniazid and rifampin, but also to one of the injectables and also towards one of the fluoroquinolones. This is the definition of extensively drug resistant tuberculosis. Approximately 9.7% of MDR tuberculosis patients are having extensively drug resistant tubercle bacilli also. The treatment is of a very long duration. Mortality is more. We have to include group 5 drugs which are more expensive and more toxic also. So this is the inclusion of the various anti-tubercular drugs from the various groups in the chemotherapy of XDR tuberculosis. From group 1, we use high dose isoniazid. Group 2, injectables, we choose capreomycin. And from the fluoroquinolones, moxifloxacin is selected. Para-aminosalicylic acid from group 4. And from group 5, we include linezolid, amoxicillin clavulanic acid, and clofazimine. So we have 4, 5, 6, 7 drugs. 7 drugs in the intensive phase. So 7 drugs for 6 to 12 months in the intensive phase. We remove the injectable, capreomycin is removed. The remaining 6 oral anti-tubercular drugs are continued for 18 months. So the duration lasts for 24 to 30 months, 2 to 2.5 years. Now, what is the regimen chosen when we are treating a pregnant lady who is diagnosed with tuberculosis? The first line oral anti-tubercular drugs are considered safe during pregnancy. They do not cause fetotoxicity. They are not teratogenic. They are safe for the fetus as well as for the pregnant lady. So the treatment is similar to what we saw when we choose the regimen for newly diagnosed cases of tuberculosis. 2 months of HRZD in the intensive phase and 4 months of HRE in the continuation phase. Pyridoxine is mandatory. Please remember, pyridoxine is mandatory even for MDR tuberculosis and XDR tuberculosis patients. So when we are treating a nursing mother for tuberculosis, please remember first line drugs, the oral anti-tubercular drugs in the first line group are compatible for breastfeeding, and the same regimen as we saw previously is used, 2 HRZD plus 4 HRE. The mother need not postpone or stop breastfeeding even though she is on these anti-tubercular drugs. As far as the infant is concerned, Isoniazid prophylaxis for 6 months is given after confirming the neonate is negative for tuberculosis and after BCG vaccination. Please remember, the breastfed infant whose mother is on isoniazid and when the infant is on prophylactic isoniazid should be given pyridoxine daily to prevent neurological toxicities which may result from isoniazid. Now coming to the chemoprophylaxis of tuberculosis, how to prevent tuberculosis and who needs to be given prophylactic anti-tubercular drugs. So those patients who are having a probably latent infection need to be given prophylaxis with anti-tubercular drugs so that they will not progress to have the active infection. So who are these risk groups? Neonate of tubercular mother, HIV infected contact of sputum positive case, immunocompromised patients, that means HIV AIDS patients, those patients who are on chronic corticosteroid treatment, those patients who are on immunosuppressants, they have received kidneys or liver from a donor and they are on immunosuppressant treatment, those patients of cancers who are on anti-cancer treatment because anti-cancer drugs are also immunosuppressants. Children who are having an open case in the family, that means sputum positive patient in the family. Exposed contact of open case who has had a recent Manchu conversion. So these are the risk groups who require prophylactic treatment with anti-tubercular drugs to prevent the progression of latent to active infection. The regimen for chemoprophylaxis of tuberculosis is number 1, isoniazid 300 mg daily for 6 months or weekly rifampin, that is and high dose isoniazid for 3 months. So this may be an alternative for giving isoniazid 300 mg daily for 6 months. Rifampin is given as 10 mg per kg body weight and isoniazid high dose means 10 mg per kg body weight. Now, how to treat the association of HIV AIDS and tuberculosis? This is a very serious situation where the patient is on anti-tubercular drugs as well as antiretroviral drugs. First of all, HIV infected individuals are 8 times more at risk to develop tuberculosis in their lifetimes. and HIV patients have a more severe and more infectious tuberculosis compared to non-HIV patients. HIV infection is the most common cause for converting a latent infection into an active infection, and the adverse drug reactions in HIV patients is much more when compared to non-HIV patients. And the possibility of HIV patients developing tuberculosis is more when the CD4 count goes less than 150 cells per microliter. And how should we prevent tuberculosis in HIV/AIDS patients? By starting antiretroviral treatment. When you treat HIV and AIDS, the CD4 count is maintained in a normal range, and this can prevent tuberculosis, and also the viral load will also reduce whenever we use antiretroviral treatment. So the regimen for tuberculosis in HIV patients is 2 months of HRCT, and the continuation phase is for 4 to 7 months. So 6 to 9 months is the duration of the regimen for HIV/AIDS patients. And another important thing here is you may replace rifampin with rifapentin, because rifampin is a very prominent microsomal enzyme inducer. Rifampin especially induces the metabolism of antiretroviral drugs like non-nucleoside reverse transcriptase inhibitors, that is drugs like nevirapine and efavirenz, more so with nevirapine, and protease inhibitors like indinavir, ritonavir, atazanavir, etc. So rifampin compared to rifampin is a very weak microsomal enzyme inducer. Cotrimoxazole is given on a daily basis in HIV patients who are on anti-tubercular treatment to prevent the serious pneumocystis jirovecii infections. So whenever we are treating the patients of tuberculosis with anti-tubercular drugs, we may encounter adverse drug reactions. So how to manage them? Number one, in case of nausea and vomiting, we may administer the anti-tubercular drugs along with meals. If the patient complains of dizziness, administer the anti-tubercular drugs at the time of going to bed. If the patient complains of arthralgia, which may be seen with pyrazinamide, use NSAIDs to reduce the joint pain. If the patient complains of neurological disturbances like paresthesias, numbness, tingling sensation, mental confusion, which may happen with isoniazid, then consider vitamin B6 pyridoxine treatment to overcome the neurological disturbances. If the patient complains of visual disturbances like problems with visual acuity, color vision, field of vision, then you may think of stopping ethambutol. So these are some of the interventions. Suppose there are serious adverse effects like hemolysis and renal failure, which may happen with rifampin. You may stop the further usage of rifampin in the patients. Suppose there is rashes and itching. You may stop the drugs, reintroduce the drugs, re-challenge with small doses, increasing the dose every 3 days. This can be done. Find out the culprit and remove that particular drug from the regimen. Hepatic damage may occur because the first line anti-tubercular drugs and even the second line anti-tubercular, some of them can cause liver toxicity. So isoniazid, rifampin, pyrazinamide can cause liver damage. So if such a situation happens in the presence of jaundice, which is seen after initiating the treatment, you may stop the whole regimen. And if the tuberculosis is serious, you may institute anti-tubercular drugs which are not hepatotoxic. For example, ethambutol, streptomycin, and a fluoroquinolone. Once the liver becomes normal, comes back to normalcy, then you can reintroduce these drugs, which may be the cause. The first drug to be reintroduced is Rifampin, and after a week, you reintroduce Isoniazid. If liver damage once again happens, the last added drug is the culprit that is removed from the regimen. Suppose Rifampin is the cause for liver damage, you continue the treatment with the rest of the drugs. The same thing applies to Isoniazid and pyrazinamide. If they are the culprits, you continue the treatment with the remaining drugs. And it is mandatory to do liver function tests before starting anti-tubercular chemotherapy, because the drugs, they are more prone to cause liver damage if the person is having pre-existing liver disease. What is the role of steroids during chemotherapy of tuberculosis? Ordinarily, they are not used, and if they have to be used, we should have an effective chemotherapeutic cover. So to treat the adverse drug reactions, steroids are used. Whenever we are treating severe cases like miliary tuberculosis, severe pulmonary tuberculosis, we may use steroids. To prevent the further exudation additions in renal, pericardial, and pleural effusion, we may use corticosteroids. And please remember, steroids are absolutely contraindicated in intestinal tuberculosis because they can cause silent perforation. So as we know, corticosteroids, they delay wound healing, and in the process, they can cause silent perforation, which can lead to peritonitis. Now, how do we treat MAC? MAC is Mycobacterium avium complex infections. This is caused by the atypical Mycobacterium MAC. And these infections occur in immunocompromised HIV and AIDS patients when the CD4 count goes to less than 50 cells per microliter. And remember, MAC infections cannot be completely cured. You don't have drugs which completely cure MAC infections. The infection can only be suppressed and made asymptomatic. So which are the drugs useful here? The macrolides, azithromycin, clarithromycin, rifabutin, ethambutol, and fluoroquinolones are the efficacious drugs against this infection. So once again, we have the intensive and continuation phases for MAC infections also. We use 3 drugs for 2 to 6 months. In the intensive phase, we choose one from azithromycin or clarithromycin. We add ethambutol and rifabutin for 2 to 6 months. And 2 to 6 months because we have to use these 3 drugs until the patient symptoms reduce or till the CD4 count goes to more than 100 cells per microliter. The continuation phase, we use 2 drugs, that is one from azithromycin and clarithromycin and one from ethambutol, rifabutin, and fluoroquinolones. So 2 drugs for a minimum of 12 months, and we have to use this continuation phase till the patient becomes asymptomatic and the CD4 levels go to more than 100 cells per microliter and stays there for at least 6 months. So this is the regimen for MAC infections. Now for chemoprophylaxis of MAC infections, that is when the CD4 count in HIV patients is less than 75 cells per microliter, that is an indication for chemoprophylaxis. We have to use just one drug, either azithromycin or clarithromycin. If they can't be used, rifabutin may be used. And this one drug is given once a day till the CD4 count goes to more than 100 cells per microliter and stays there for at least 3 months. So this is how we use drugs for chemoprophylaxis of MAC infections. Please remember, the patient, HIV patient, is also on antiretroviral treatment. During the period you are treating the patient for tuberculosis or even MAC infections. So to summarize this lecture session, we have learnt about the various regimens which are used for the various categories of tuberculosis patients, ranging from multi-drug resistant tuberculosis to the patient who is also having HIV or AIDS and on antiretroviral treatment. The prophylactic regimens which are used in susceptible patients to prevent the emergence of tuberculosis, how to manage the adverse drug reactions which are seen as a result of using anti-tubercular drugs, the role of corticosteroids during chemotherapy of tuberculosis, how to manage patients of HIV who are infected with tuberculosis, who are on both antiretroviral drugs as well as anti-tubercular drugs. And we have also studied finally the treatment and prophylaxis of Mycobacterium avium complex infections. So I come to the end of this particular lecture session. Thank you very much and happy reading.